So, questions. I think most from my doing patient forums, I think most patients, when we look at the feedback, will say, look, we derived the most benefit from when we had the chance to ask questions at the end of the talk. So I'm very conscious of that. So if there's any questions I could take from the, yeah.
Have you performed any knee operations with robotics?
How do we do it?
No, have you done any?
Okay, so I have, my total experience is over 100. So I was the first to do this in the north of England. So I was the first to do the partial and the total and the combination of partial, total, and total knee and total hip. So I have done and listed over 100. So my experience is certainly they've been uniformly good. I mean, obviously the recovery, there's a recovery time associated with these joint replacements. So you can't get away from that. But what this reassures me is that is the technical approach to surgery. So obviously there's a structure to the knee or hip joint. You got to restore the foundation of the joint, just like when you build a house, you got to get that foundation right. Then obviously the furnishings. The furnishings for me, the analogy is the muscle strength, right? That as a patient you can't run away from, right? So you got to still do it. But what I can do is reassure you in relation to the technical outcome of the operation. And in my experience so far, it really reassures patients of that, and it allows them to focus on the rehab. And this has, to me, the highest, it increases the potential for a natural feeling joint. That's what you want, isn't it, as a patient? You want a joint that you can forget about. That's the ultimate goal for me as a surgeon, yeah. Yeah. So the question is, do you have a general or a spinal anesthetic? So generally, we advocate a spinal anesthetic because that helps with the pain relief afterwards, and patients can choose how much sedation they want. So the degree of sedation is varied according to the patient. For most patients, they don't really want to be a part of it. They just want to be sedated, and so that's the preference. But yeah, you do it under spinal and general anesthetic generally. So there's a move towards combining this technology, for instance, with day case surgery. So in other words, just do this as a day case and then home. But it doesn't eliminate the fact that as a patient you still have to recover from a major operation. These operations are still considered major operations, but all these refinements has given us the reassurance of a higher likelihood of a better outcome. That's what it is. Yeah, questions. Sorry, can you?
Are there any hip replacements, any types of hip replacement you wouldn't use?
That you would do?
You wouldn't.
You wouldn't, right. Okay. Okay, so you're talking about my own practice as in relation? Generally. Yeah, so if you look at my practice, so what I tend to do is try to stick very closely to the results that are offered to us by the National Joint Registry. So every single joint in the UK, my own, my colleagues, the whole country, England and Wales certainly, is registered in the National Joint Registry. So we've had this, it's been ongoing for 14, 15 years. So I'm guided by that experience. So the National Joint Registry reassures me that the implants I use are the ones that I should, because they've got good long-term results. So, and that is supported by the MACO. So I'm talking about the stem. Yes, I would, but obviously you do have patients who are medically perhaps a little bit more frail, right? So you don't want to spend an extra 20 minutes or 30 minutes on a patient where you can do it 30 minutes quicker. So this does add about, my experience, 20 minutes to the operation. So, but generally I don't see it being an issue. And also with the MACO, you essentially put an uncemented cup. So essentially you jam the cup in as opposed to cement it. So for some patients, some older patients, they would benefit from having a cemented cup, and that's not supported by the MACOs. So I don't use it for all comers, but the biggest demand I find in my practice are patients who are, physiologically young. But I mean, you could be 80, but you're fit enough to be considered a 60-year-old, and you really want the best possible function, and you want kind of like the Ferrari of hips, for instance. They want the most well-positioned implant that would fulfill their needs. And these are the patients that want something like this to ensure that they have equal leg lengths, they have the perfect alignment, so that they have less chance of complications from the hip catching and the hip popping out. So that's the main advantage of using robot assisted for hip replacements. It's about alignment, about leg lengths, about stability. Sorry.
Sorry. Have you ever been faced with a hip replacement where the damage caused by the arthritis or the wearing of the socket is just too bad? And if so, like, how have you resolved it? What have you done to?
Yeah, so there are different, you're absolutely right, you know, there are different severities of arthritis. So the most severe arthritis is one where, you know, the challenge is that there isn't enough bone to reconstruct the hip. Okay, so if, for instance, if you have a very shallow hip and the hip is very soft and it's all the way back into the pelvis, so there's always reconstructive options, but it gets, you know, more and more complicated the less bone there is, and if there's less soft tissue coverage. So the answer to you is yes. You know, obviously in my training I've been exposed to the whole spectrum of severity of arthritis, but the more difficult ones, the more complex cases are ones where the bone stock is a challenge. So we can make custom-made implants. We can have cages and all kinds of you know, technology now is available for that. But you know, they become more and more complex. But certainly, yeah, it's out there, it's available, but the complexity of those kind of operations are obviously much more than a routine.
When is the right time to do a hip replacement?
So the question is, what's the right time? And I think the answer to that is that it's individualized to that patient. Because ultimately, a hip replacement or a partial or a full knee replacement is a quality of life procedure. So it has to be tailored to that individual. So with a lot of doctors, they will say, look, you know, it's you're too young, or you know, your symptoms are not severe enough. That's often the points that are raised, you know, to challenge patients who ask for referral for a knee or hip replacements. So what I see the full spectrum. So I see patients who are very demanding of their lifestyle. They want to stay active. They want to remain being able to ski, to run, and all kinds of activities, but they have symptoms that prevent them from doing that, right? So my approach is to start off with the simple things that I've shown you, right, and then work up that ladder of intervention tailored to that patient. But if that patient has symptoms that restrict their lifestyle, and that's what it is, yeah, if it restricts, it causes you awareness of symptoms that affects you, then you should consider it. And that's where your relationship with your surgeon is very important, because he or she will assess your arthritis to see what options there are apart from joint replacement surgery. So it's to answer your question, I know it's a very roundabout way of answering it, but it's individualized to that patient's specific requirements. Because you and I know, right, we take the absence of pain for granted, isn't it? When we don't have pain, we don't think, oh, I don't have pain today. But if you have symptoms, doesn't matter whether it's the hip or the knee or the back, it's constantly on your mind. And if it's constantly in your mind and it affects you, you think about it first thing in the morning, you think about it last thing at night, it stops you from sleeping, certainly you will be a candidate for further investigations and treatment. I hope that answers it, but it's a pretty roundabout way of answering it. Yeah, sorry.
How long does they last?
Okay, so research has shown nowadays that the standard hip or knee replacement, certainly if you have an average hip replacement, so average age of hip replacement around 60-ish, that it would last over 20-25 years. So the odds are, if you have a hip replacement or a knee replacement above the age of 65, that's the only joint replacement you need. Now, if you're in your 40s or your 50s, there is a 1 in 5 to 1 in 3 chance. So let's say a 20 to 30% chance of needing a second joint replacement. So actually the outcomes have significantly improved compared to when I started training 20 years ago, when patients are told that your joint will last for 10 years. You need another revision. So now the vast majority of patients, if you look at the data, if you have a joint replacement surgery in your 60s, that's the only replacement that you'll need. But again, that also, there's a reflection on wear as well. So if you're 60 but you run marathons, or you're very, very active, there's obviously there's a higher potential of wearing it out. So it's a function of use and wear. So I have a question around here. Sorry. I'll come in.
You mentioned hyaluronic acid injections.
So the question is, hyaluronic acid injections, are they available on the NHS? So in the past, hyaluronic acid injections were available in the NHS. And I think in some commissioning groups, I'm talking about the whole of England, there are some pockets that still use it. I think the vast majority of the NHS now won't approve it because they say it doesn't cure arthritis. It's not cost effective, so as a general population, it's not cost effective. So that's based on National Institute for Clinical Evidence, so that's NICE guidelines. So it's not to say it's not effective. It's not effective for what the NHS wants, which is to cure you of the symptoms. So I'm afraid it doesn't cure you of the symptoms, but for the vast majority of us, we don't want surgery if we can help it. This will help. HA, in my experience, doesn't cure it, but it helps buy you time so that your symptoms are less, and also allows you to do the things that I think can help you. Okay. So question?
Do you have a meniscus there that can't be repaired due to the lack of blood flow?
Yeah.
Or it can't heal naturally, for example. If you want to get back to load weight bearing sports, would it be necessary typically to actually have some surgery or operation?
Okay. So this is a very, very common condition, problem. And the question is, do you mind if I repeat it? Yeah? The question is, I've got a cartilage tear, and when is it appropriate to have surgery? Because it won't heal, so when is it ever appropriate? I'm paraphrasing your question, but...
Yeah, I mean, I think if I understand it properly, some things I've read that the blood flow is getting into one of the parts of the cartilage may
heal. Yeah.
naturally.
Yeah.
But if it's part of the cartilage that basically has not got the blood flow, and you want to do load-bearing sports,
How do you address that?
going to get back
Yeah.
to do any of them, or
Okay.
how?
So the question is, when is it appropriate to deal with it surgically? What other options do you have if it's not appropriate for surgical management? So the thing about cartilage tears, I mean the meniscal tears or soft cartilage tears, is that in itself, the underlying issue must be addressed. So in other words, if you are above the age of 35, okay, the chances are your cartilage tear in the absence of trauma is what we call a degenerate one. So if you remember the video that I've shown you. So that cartilage tear will not heal because there's no blood supply. So the question is, if you have symptoms, I mean catching or pain with turning activity. So if you turn, it catches, then that patient may be a candidate for keyhole surgery to address it, provided the patient hasn't got any significant arthritis. So that is the key, is the assessment of the underlying loss of hard cartilage. So it's amenable to treatment with keyhole, but you've got to look very carefully for arthritis. And that's where your doctor comes in with the right x-rays and imaging to help you understand it. Now, if it's not a candidate for keyhole surgery, there are other things that can be done. So I've mentioned some of these things, the injectables, to help support the soft tissues around it to address the symptoms you're getting from the loss of the hard cartilage. So assessment of that problem on an individual basis is absolutely key to help with your symptoms. But it can be dealt. It's very common.
Do you have a knee problem at all?
Do I? Yes.
Is it your knee?
I have a knee problem. I had an ACL in the past. I had a cartilage tear. So this topic is very, very close to me. And I probably have arthritis. At the age of 47, I for sure I have arthritis in my knee. Yeah. So sorry, there's a question here. So I'm going to move around so a question. Yeah.
You talk about a bike.
Yeah.
I can't use a bike. Obviously, the movement makes my arthritis in my knees worse. So what can I do?
So the question is, I can't manage a bike because the movement makes my pain worse. I can't manage it. So I think in that situation, if you really can't use a stationary upright bike, there are spinners that you can try that, so that you can sit so that you're spinning in front of you. That's one. The other option is hydrotherapy. So for instance, here in Spire Manchester, we have a physiotherapy department with a pool, so a hydrotherapy. So the idea is that you want to keep the knee moving but not loaded. So anything that allows you to do that is going to help. So hydrotherapy is an option. Treadmill, because you're loading, right? You're standing on it, perhaps not the best idea. So the idea is that you want to reduce load, but get the heart pumping, okay? So get the heart working so your fitness is up. You can optimize your weight that way, right? And reduce the load. That's what it is. It's all about what you can control as a patient, which essentially involves reducing and optimizing loads through your hip or your knee joint. That's what it is. Walking is fine, but again, walking is loading it, right? So I'm not saying don't walk. That's absolutely not what I'm saying. I'm saying is that it's neutral, because some patients find it difficult to walk the distances that they want to walk because they're limited by pain. So what's the way around it? How do you reduce that load through the knee? It's not easy. Bike is one thing, swimming, rowing, these are the ways. Yeah, rowing machine, yeah, if you can. But it involves deep flexion of the hip and the knee, yeah. So think about how you can influence what you can influence. You can't influence the structural aspects of it, okay? You can't change necessarily the hard cartilage loss, but you can improve loading. That's the key, okay? Improve the loading through your joints.
Electric bike.
Electric bike is the suggestion. There's a couple more questions. Yeah, sorry. Yeah.
With hip replacement, is there a prevailing increase in the interest in ceramic
Yeah.
as opposed to metal?
So the question is there an increase in the interest in ceramic ball bearing, the ball side of the joint, instead of the metal on metal? So the answer is absolutely yes. So if you look at 10, 15 years ago, there's a big surge in metal on metal hip replacements. They were thought to last forever. You have very good wear characteristics of the metal on metal in the lab. But what has been shown subsequently is that when it's implanted into the patients, in some patients, and it's got to do with the design of the socket, it can cause what we now refer to as adverse reaction to metal debris. And what that has meant is that the soft tissues around the hip gets destroyed. You have muscle loss. So the uptake of metal on metal has gone right down. So it's less than 1%, certainly in the UK, of patients who would have metal on metal. So yes, that's absolutely right. There's a move towards either metal on highly cross-linked poly, so high-grade plastic, or ceramic on plastic, or ceramic on ceramic. So my practice is very much ceramic on poly, ceramic on plastic, or metal on plastic. Yeah. So a couple more questions. So it's a lady in a gray, orange cardigan. Sorry, I think you just, yeah. So the question is, if you have arthritis in your hip, does exercise aggravate it? Yes, it does. The load-bearing exercises will aggravate your pain. So again, in the hip as in the knee, non-impact exercises is key. So the same. So this is a very convenient talk for me because I've suggested the same thing and it covers both conditions. So again, non-impact exercises, use of an exercise bike, and I advocate exercise bikes to all my patients, right? And I see some of my patients, a couple of my patients in amongst the crowd, and you know what I'm referring to. And the reason why I talk about the use of an exercise bike is in relation to compliance. It's very hard to have the discipline of going to the gym because there's so many steps involved, isn't it? You got to decide to go to the gym, right? You got to pack, you got to get into the car, you got to get changed, you got to go to the gym and use the gym, you got to get back out again. So there are too many steps involved. So the exercise bike is the best form, if you like, of exercise for symptomatic hip and knee osteoarthritis because it's non-weight bearing. It increases the symmetry between the two joints, increases the muscle symmetry, right? So that all the muscles are talking to each other in the right sort of way. Increases the heart rate, increases the blood supply to the structures around the hip, helps nourish and hydrate the cartilage around the hip, okay? And if you do it little and often, the key is little and often, the consistency, right, is absolutely key. You combine that with core type strengthening exercises, you offload the hip and the knee joint, and that I find is very, very effective. Of course, there's an extent, there's different degrees of arthritis, but certainly in general that helps.
What's the least you can get away with? You say little.
What's the least you can get away with? And the answer is 10 minutes is better than nothing. 5 minutes is better than nothing. So I do this myself, right? So I practice what I preach. I absolutely do, right? So every day at 9 o'clock at night, okay, I exercise for 20 minutes. That's what I said to myself. 20 minutes without fail. For the last 2.5 years, I've done this. 20 minutes. Okay, I've got my own exercise regime. But it's consistency in doing that. That's the key. So if you go on a bike for half an hour or 40 minutes, guess what? That's the last time you're going to do it, right? Because it's so difficult to do it for 40. I know. Yeah. I struggle with it myself. But if I say to myself, I'm just going to do it for 15 minutes, just 15 minutes, right? Then that 15 minutes can be 30 minutes one day, and it can literally be 15 minutes or 10 minutes another day. But it's having the mindset of doing it on a consistent basis. That's the key. So this question, sorry.
Would you recommend a hip replacement for persistent bursitis?
Okay, so the question is, would you recommend a hip replacement for persistent bursitis? The answer is absolutely not, because bursitis is a soft tissue condition in itself. So I'm assuming you mean bursitis in the absence of hip arthritis. They're totally different conditions. They can coexist, so you can get severe hip arthritis and concomitant or associated bursitis, weakness. You can. But in itself, bursitis is a soft tissue problem. Often patients with bursitis have an overuse phenomena, that's overloading, right? That causes bursitis. And in itself, that needs to be addressed. You need to address the poor healing and the overloading. But in the absence of arthritis, hip replacement is not indicated. You've got to treat the bursitis. Yeah, the underlying issue. So I think I'm going to try to work my way back this way. Yeah.
Whilst you're waiting for either surgery or further treatment, would you recommend any taping or strapping or support?
Taping, sorry, yep. So absolutely right. Oh, by the way, don't feel that don't feel obliged to stick around. For those who wish to go, thank you very much for turning up, and I'm sticking around for as long as you wish me to help answer some questions. But if you got to go, please don't feel that you got to stick around. But the answer to that question is absolutely. There's a whole range of different modalities. So taping, acupuncture, soft tissue releases. These are all, remember the tool mounted with the tool belt that I was referring to? These are the various things that we can do. So taping, the physios are great in that. They essentially look at your alignment, they look at your soft tissue balance, and they look at what muscles are working more than the other. And of course, based on that, they will be able to advocate the appropriate types of bracing and supports and what have you. Yeah, question in front here.
If you've got an issue with the hip area, and you've been through all the NHS checks, ultrasounds, physio and that, and you're still in pain, but they just say it's not bone on bone, so there's nothing there, everything's borderline. Is the initial thoughts we were to come privately to have some look at it, to actually replace it? It's looking more and more like, can you come privately to see a consultant to get advice on what's wrong?
Yeah, of course, yeah.
And would it be yourself or would it be somebody?
Yeah. So the question is, if I've got a problem and I want it assessed, can I ask to see you and do it? So basically the answer is yes, you can specifically ask to see me as opposed to somebody else, but equally you're not obliged to follow on to the treatment. You can just attend, and I think I see about 20 new patients in a week, and maybe one or two go on to need some sort of intervention. So the vast majority of them are actually advised and to give non-operative treatment advice and intervention. So that's essentially the question. Yeah. So you can absolutely do. Sorry, I know you've got you.
The hyaluronic acid and then the platelet treatment, how severe would you offer that for the arthritis in either the hip or the knee? Like, how severe would it be where it's like a weak severity or like a really bad severity, or where would it be where it's just a bit like, this is a pointless treatment because it's not going to help anything?
So it's, by the time you reach bone-on-bone arthritis, these interventions tend not to work. So in general, if I don't see bone-on-bone arthritis, I would try to offer everything else. So it's bone-on-bone arthritis. You see in the x-rays I've shown you, right? Bone-on-bone arthritis means you've lost all the cartilage on either side of the joint. So the thigh bone side, the shin bone side, or the ball side and the socket side. Before that, I would try everything else. So my approach is very much give the patient time, help patients understand what the condition is, try the absolute non-operative treatment if possible, supplement that with injections, and the different types of injections we talked about, and then give them more time. And then essentially, if you've exhausted all of that, do you consider surgery? And even then, if I don't see bone on bone, I would say, look, address the muscular side of things. Because the bone on bone refers to the structural consequences of arthritis, but there's also the muscular side. So by that I mean, if you still have joint space, it may mean that some of your symptoms are muscular as opposed to structural in nature.
And which out of the two would you recommend being sort of like the best results?
I think there are pros and cons to each.
Yeah.
So certainly the HA, I have patients that love one, swear by one, and there are patients that love the other, swear by the other. And equally, there are patients that, you know, try both and they don't both work. You know what I'm saying? So there is a spectrum. These therapies are not meant to cure you. They're meant to buy you time, and as much time as possible. And the big advantage of these therapies relate to the cumulative effect. You know, it's not like steroid injections. You have one, you have two, you have three, and you know, it makes joint worse and worse, yeah, because of the effect that cortisone and steroid have on the joint. But the big advantage of these therapies, the HA and the PRP, relates to the cumulative effect. You know, it doesn't harm, provided it doesn't get infected, and obviously there's a small risk of that, but very, you know, in my experience, I've not had any of that. But there's a risk, the risk is much smaller, and the cumulative effect is very attractive to patients.
Are these three
I'm not going to answer that.
Are these three
So, Cass, sorry.
What is the successful rate for half knee replacement and a full replacement?
Okay, so the success rates of a partial knee replacement, if you look at the National Joint Registry, is not as successful as the full. But that relates to how well the partial knee replacement is done. So that's why a lot of the research is focused on how we can improve that. Because you can see the advantages, right? You can see such a small implant that's been, you know, that you can potentially put instead of a massive one. And this is a much bigger operation. You take far more bone and so on. So the difference between the two, research has shown, relates to how well this is done. So the joint registry shows that the failure rate of the partial is higher. So to give you a figure to hang on, 5 to 6% failure at 10 years as opposed to 1%, 2% failure at 10 years. So it's much higher for the partial, but you can see how this has really changed the way we looked at how well we can improve on that.
If you only need a half replacement, can you do full?
You can also do the full. So there are some patients who are much older in whom the risks of having to do it again are outweighed by the benefits of just doing a full at the outset. So you have to look at the individual patient. Yeah. So there's a question here. I kind of, maybe I'll take one or two questions, and I'm more than happy to stick around so that I don't feel that everybody is about. So Cass, sorry, there's one.
Before you mentioned you've done 100 procedures, is that just robotics or total?
No, the 100 or so procedures I've done is just the robotics. So in my own experience, and you can check this on the National Joint Registry, I've done over 1,000 hip and knee replacements in what's in the National Joint Registry, and in my career about 2,000. So it's quite a large number overall. But I am 47, and I've done So correct.
How long has robot-assisted knee and hip replacement been going?
Has been going right. So in the States, over 5 years certainly.
So, because obviously you trained on the.
I train on a conventional.
Conventional.
Yeah.
How long did
What's-
the training take?
what's the
before you
learning
felt
curve?
Comfortable doing robotics?
Okay, it's not just me, but research has actually looked into the learning curve associated with robot-assisted joint replacement, and it's 7 cases. 7 cases. So, but before we try it on real patients, obviously we have to have the training, on the cadaveric courses and, attending at other people's place, So obviously we're very experienced anyway, you know what I'm saying? So it's not that big a transition, but the first few cases, obviously my first case, I think I took 3 hours to do it. But, it's just because you're far more cautious and, you got to be sure that you're but that's 7 cases is the learning curve is what has been documented in the literature, yeah.
So if it's bone on bone, I was advised to leave it as long as I can before having a replacement. So would a partial one just there, would that suit me?
So the question is, I've got bone on bone, I've advised to leave it, but every individual patient is different. That's why I can't really comment on your specific case, and there may be a reason why doctors will say, leave it. But basically, if it's bone on bone, it's as severe as it gets. And we know in clinical practice that generally in the knee, one compartment is more affected than the rest. I'm not saying that's for all the cases. I'm saying 40-50% of cases, you can say that compartment is more affected than the other. So in general, we can afford this solution. And the reason why it's not as widely available is because we don't want a poor outcome. We don't want to do a partial, and if it's slightly malaligned, for another surgeon to say, oh, look, we should have just done a full knee and then it'll be fine, So that's the risk-benefit analysis that we have to employ.
So I need a consultation.
Yeah, I think you need to have a look at it, yeah. So,
Is the HA and the other blood therapy available on the NHS?
so the HA and blood injection, so again, the HA and the PRP, in very certain locations and situations, it may be. But because it's to do with cost constraints. So I think there's a move towards trying to get PRP recognized in some CCGs, clinical commissioning groups, but I don't know the specific details of that. But generally, I think you would struggle in this day, in our current climate, but you can still look into certain CCG, clinical commissioning groups, that say, yeah, we're prepared to fund it because we've seen the research that supports its use.
You keep talking about the things you can do to buy time.
Yeah.
Why buy time?
Okay.
Why not just have it done?
So the question
I
is.
can't get my head around that
Okay.
one. I'm sorry.
Okay. So the question
To me,
is.
I just have it done.
Yeah.
Because
So-
it's
so-
going to be done in the end, isn't it?
Okay, so the question is, why buy time? Why not just have it?
Yeah.
Okay, so the very simple answer to that is that if you don't have, and I can refer to this over and over again, if you don't have bone-on-bone arthritis, some of your symptoms may not be due to the joint itself.
But
It may be due to
You
the,
probably end up having it done in the end, so why not have it done?
because you may not need it.
Right.
That's the point. So the point is that you may actually never need a joint replacement.
Right.
So what we're trying to do is
But
to
when you
work
said
out.
buying time, I thought, oh, you're going to end up with it in the end anyway.
Yeah, you may not. You may
Because,
not. Yeah.
You know, the way you said buying time.
Okay.
I
So
thought-
it's to work out whether or not we can address the muscular aspects of your symptoms sufficiently enough that you find your symptoms manageable. So if we scan and x-ray every of our joints here, I think we will find that a significant proportion of us will have changes of arthritis, either on the x-rays or the scans. But we don't all need joint replacements. Maybe a small minority of us do. But we all have symptoms, for instance. Okay, so what I'm trying to say is that these buying time measures allow us to work out which of us actually need a joint replacement, because the rest of us could manage by just addressing the muscular and the loading imperfections of our joints that's causing us symptoms. That's the point. Okay, I'm going to take maybe one final question, and I'm going to let the rest of you go out, because I feel that but I'll stick around, more than happy to take your questions. So final question, yeah.
Hip impingement.
Hip impingement.
Yeah, I'm due to have an injection on Friday. Is that really the best way forward?
Okay, so the question is, I've got hip impingement, I'm having an injection, is that the best way forward? So the first thing to say is that hip impingement is very common in the general population. This is a structural problem in the hip where the bony abnormalities is thought to cause or predispose patients to early arthritis. So the injection aims to understand the origin of that pain, because the hip's deep inside. I think you've seen the pictures of where the hip is, right? It's deep inside. So you don't really know whether the hip joint or the impingement is the cause of your symptoms. So what the injection does is helps you localize it. So you have an injection and your pain goes, then you know your pain is arising from the hip joint or the impingement. Then you can decide what's the next step to do. Now, if you have a hip injection and you still have pain, that means that the hip joint is not the problem. So it has a diagnostic help. That's the value of the injection, is to establish whether or not the joint is the problem. So if you have no improvement, you should think about, could it be the muscles around the hip? Could it be tightness? Could it be referred pain? Could it be another problem? So hip impingement itself is not a reason for further intervention. Hip impingement is very common. You've got to put it in context. And this is where your doctor, your surgeon, or your physio puts it together for you. So he'll ask you, assesses your symptoms, examines you, does the x-ray, does the MRI scan to help understand and arrive at a secure diagnosis that then allows us to treat your symptoms. That's the reason for it. So have the injection, but keep a diary. So thank you very much, everyone. It's been such a long evening, but thank you very much for coming along. And I'll be sticking around to answer, happy to help with any questions. But it's been a real pleasure to speak to all of you. Thank you very much for coming along to Spire Manchester. And thank you, Spire Manchester.